He's like, I'm getting paid for this.
What are we doing here? Well, we definitely wanted to address the elephant in the room, which is businesses are heavily influenced by HR leaders. And
Yes.
we're finding that HR leaders are resistant to change for multiple reasons. But the main one is probably the fact that they're wearing too many hats. They've got a lot of things going on. End of the year comes fast. A lot of compliance issues they've got to deal with. A lot of employee relations issues they've got to deal with. So simply signing that 2% renewal seems to be the quickest way to put it to bed.
Time is what you're talking about.
Yes.
That's the amount of hours in the day. And I was chuckling a little bit because, as you know, we have an HR team. They were set to go home early for the day, and there was a phone call that came in with a new complaint.
Yes.
That has to be addressed immediately.
Immediately, huh?
And so I think from an HR perspective, we understand it just never stops. That it's a constant flow of things that have to be addressed. And so I think you're right. From their perspective and having really good conversations with them, you know what, if it's working and it's in the budget, let's not mess with it.
Yeah.
Disruption, moving a carrier or changing a plane designs can be disruptive.
Sure.
There's rewards in it, and I think we just have to have the conversations of whenever it's right, right timing for the company to make these changes.
Right.
Because there's a trade-off, because there's time involved in making the move, but the reward from that is that we're improving the benefits for the members and we're improving the cash flow for the employer.
Got it.
So it works. However, I think it's only scheduled when the organization is ready to do these types of changes.
Is it a matter of someone having a pain point or a need immediately?
Ironically, it's when you get the 2% renewal. Because it's much easier to sail through the waters when the sky is blue. If there's a reaction because we have high cost claimants, well, high cost claimants are going to create a high renewal. So when you're in the throes of a high renewal because of high cost claimants, that's going to impact the strategies that we use to put in place, with the self-funded designs and underwriting. And so it's not as smooth when you're fighting through a bad claims year. Because statistically speaking,
Right.
A self-funded plan is going to get clobbered 20% of the time, 15% of the time.
Got it.
So, somewhere in that neighborhood of 1 out of 5 to 7 years, it's not going to look good.
Yeah.
But on the average, it works. But going back to my original point is that the irony is that you'd want to do it when the skies are blue, and you have that 2% renewal, because you want to then put these strategies in place, communicate them, get used to them, so then when you enter into that new high cost claimant, arena or scenario, we're prepared for it. And now we have tools in place that we can make sure that the members are being redirected to the appropriate sites of care. And when I talk about appropriate, I'm not talking quality. I'm really talking cost versus quality, because the studies that we see, especially with electronic medical records, we can track hospitals. We know hospitals' readmission rates, we know complication rates, we know infection rates. And we're learning that if we move somebody to an independent, outpatient facility, their cost is the fraction of what it would be in a hospital system.
Sure.
However, the quality is higher.
Mm-hmm.
Because that's what they specialize in over and over and over again. And so when we talk about getting them in the appropriate set of care, number one, it's working with an advocate, because if somebody's going through something that's requiring a hospital stay for themselves or somebody in their family that they care about, you're emotionally charged.
Right.
The system is opaque, the system is confusing, and if we can have a member talk to an advocate to help schedule appointments, to help answer questions, to review EOBs, to give confidence to the member or the member's dependent or spouse that's going through a treatment program. If they can get more confidence of why they're going where they're going, in addition to reducing their out-of-pocket expense, then we've reduced the stress for them emotionally. We're reducing the stress for them financially because we can reduce their out-of-pocket expenses.
Yep, that's real money. Yep.
And that's really what we're talking about. It's great to say I can save $25,000 on the claim to a plan sponsor.
Yep.
But it can't happen without a claim. And when you have someone going through a claim, it's, they're emotionally exhausted.
Right.
And so we really have to have the conversation of how do we make sure that our members are experiencing something positive in a time of their life that is not positive. Because, productivity in today's labor market is real.
Yep.
So just, from that perspective of the employees, stabilizing them, that helps stabilize the employer relationship with them. Productivity is not going to be as impacted.
Right.
So there's just a lot of, reasons to do these strategies, but it kind of all goes back to your original question is let's do it when the skies are blue.
Sure.
Because it's a lot harder to sail through a storm than it is to sail through calm waters.
So with that being said, right, so we're seeing that, again, coming down to timing, you get that 2% renewal 1 to 2 months before your renewal date.
Right.
Is it better to discuss these strategies at that time, knowing that the HR leader is probably going to sign off on it because of the timing, or how many months ahead would it make sense for us to maybe take over the AOR and start looking at data so that we can implement these strategies when it comes time to renew?
Well, that's a good point, David, is that it's, our industry has been so compressed because of healthcare reform. So, the number one renewal date's January 1st. The number two renewal date is December 1st. And there's a lot of reasons behind that we're not going to cover today. But because everything is so compressed, everything has to move very quickly
Right.
for a lot of different organizations.
Right.
And I think it's best to start the process much sooner so that we can be prepared for it.
Yep.
We should be having meetings in February and March on plan designs, strategies around what the costs are going to be
Yep.
for the employee members,
Yep.
strategies around the different alternative ways to do things,
Right.
so that we can kind of, build it before the renewal comes.
Exactly.
You mentioned data. It is absolutely appropriate to crawl before you start running.
Sure.
So these strategies take time, and through our process, it's crawl, walk, run, as you know, where you start slow, then you can start making some changes, maybe next year, the following year, and then you start making decisions on do we want to even go faster?
Yep.
So working with an employer, becoming the agent of record does not mean immediate change. But what it does mean is let's start educating everybody about how the true operation of the plan is going.
Yep.
And is there excess money being spent for things that we don't need to spend it on?
Sure.
And then create a 3-year plan initially. So at any time we take over a new organization, we do like to outline a 3-year plan so that everyone kind of has the expectations. I have some companies that say, you know what, I want to go to year 3 right now.
Yep.
Fine, as long as we go into it with eyes open.
Right.
But most organizations, specifically for what you start off with your comment about just time in the human resource department, because no matter what we do from a communications perspective, it all lands on HR.
Yep.
During
That's my
the
next
year.
point. Exactly.
Always lands on HR during the year.
Yep.
So if we can, create the environment where we can kind of start walking into it, they start understanding it better. They feel more confident answering the questions.
Yep.
I have some clients that never leave year 2. We're 4 years into a relationship, 5 years into a relationship, and they're still on, year 2, as we call it.
Mm-hmm.
And that's fine. It works for them.
Yep.
Let's continue doing it.
Right.
Improving benefits, managing costs, but it's really about educating everyone of really where all the dollars are flowing. And the irony is that the CAA, which we've been talking about a little bit, is really putting a focus on that. So anybody that has managed a retirement plan, back in 2006, I think it was, right? John Deere was the first company that got sued for a fiduciary breach of responsibility for excess fees inside the retirement account.
Yep.
Well, Johnson & Johnson is our John Deere.
Mm-hmm.
And so we have a fiduciary responsibility to make sure that we know where things are, where our members are going and why they're going there and what the costs are, and are those costs reasonable? I mean, it spells it out specifically.
Yeah.
Is what you're paying reasonable?
And it's funny that you had mentioned that was kind of the tip of the spear, right? So that Johnson & Johnson lawsuit, but now you're seeing other lawsuits, and sorry to kind of pivot here, but talk about, misconceptions and just misunderstanding of the healthcare system. We're starting to see PBMs, pharmacy benefit managers being sued. Can you speak a little bit about where you kind of see this all heading, and then how can Arcwood help these companies kind of navigate this complex change?
Well, I think the global question of where do I see it all heading, which is the culmination of the plan sponsor suits to the PBM suits, and there'll be more suits out there. Yeah, there's going to be every other category that's in between inside there, is really going to come down to transparency. The one thing that I learned from running our 401k organization is that everybody is concerned about process. Every agency is concerned about process. Not once does it say you have to pay the least, but it has to know
why.
But the statement in there is, do you know what you're paying?
Sure.
And are you okay with it?
Sure.
And I think that's my wish, is that it's going to come to a more transparent environment, so that plan sponsors have the opportunity to make decisions that are right for their company.
Right.
Because it's not. We can't make decisions based on dollars. We also have to make decisions based on member experience.
Of course.
Especially in today's labor markets.
Yep.
And I say today's labor markets, but guys, I think this labor market's not going to change.
Yeah. Recruiting, retaining talent will be an issue for a while.
It's like we've been saying the insurance industry is not sustainable for 10 years.
Exactly.
I'm sorry, the labor market is going to be crazy for the next decade as well.
Exactly.
Everything I see from talking with our HR team.
Yep.
However, but kind of going back to that point, is that we can't make decisions specifically on dollars, but we have to know where the dollars are going. Mm-hmm. As a fiduciary on a plan, I need to know that if my members are going to facility A and it's costing me $30,000, or they can go to facility B that's a block down the road and it's going to cost $10,000, and the quality is the same or better.
Right.
I need to come up with a solid reason on why that's okay.
Yeah, exactly.
So if an agency knocks on my door and they say, "Why are you spending $30,000 when you can spend $10," I just need to be prepared to answer that.
Right.
And today, I don't think anybody is.
Gotcha. Makes sense.
Well, I think that's where you were going with it. Is where does our Arcwood fit in this position?
Yeah, and I was just going to
in this conversation
throw in death by a thousand cuts, because that's something you love to talk about, and I love that analogy.
Right.
But if you want to tie that in, kind of going back to data and transparency.
Right. It's our AAAs. It's our tenant, where we want to make sure that we have access to data, and then we want to align the benefit plans with the company mission. Honestly, is what it boils down to. I mean, and really, what that means in English is we want to make sure that the employees that are recruiting are on the same page as the folks that are in the benefits.
Right. It's funny how they don't talk, right?
We find that there's a disconnect there.
Yes,
so that's kind of the alignment aspect of it. But then, going back to my original comments about the members, is that we have to award the members.
Of course.
Because anytime we do something, it's change. If anyone's read the book Who Moved My Cheese, change is hard. And so we have to award the members by reducing their out-of-pocket and increase their financial wellness. So that's kind of what we do, is like we come into the picture armed with the knowledge that we can share with our clients and the tools that we can find out what things cost, where things cost, what the quality is, because our HR teams aren't going to do it. Our CFO teams aren't going to do it. Our CEOs are not going to do it.
Yep.
Our employees are not going to do it.
Sure not.
People going through treatment are not going to do it.
Right.
And so the value that Arcwood brings is that we have the knowledge and the tools to bring to the table to get all that information to them.
Yep.
So that's really where we stand from the benefits perspective.
Do I hit on employee education, like how, right? Because we see number one issue.
It's a touchy subject right now,
I
David.
know. Because you heard all these great things that we can do, yet people are resistant to change.
They are.
And even if the
Rightfully
change,
so. It's
even
hard
if-
for me to change stuff.
I know. But even when the changes are made, it has to get disseminated down to the employees, right? So
It
that
does.
so that they actually understand what is being presented to them, what's being offered to them, I should say, how to utilize those benefits. You know, how you're saying, instead of going to facility A, you go to facility B. You're being steered one way or another, right? I mean, you're either being steered by your primary care physician or that network
Yep.
to go to another service provider within network, or you follow our advocacy program, follow the advocate's suggestions, and now you're financially better off. And so that word tends to kind of have a negative connotation, steering. But if it's going to save you 40%, 50%, why not? And so I think that's the biggest challenge right now, is getting employees to understand
Yeah.
that
Because employees don't want to take the time to do this.
healthcare prices are negotiable.
I mean, the communication strategies is really, it's got to be a global education of, it's going to look different, it's going to feel different. You have the same network of physicians that you had before. That doesn't change.
Can you repeat that?
That you have the same network of physicians. Yeah.
Okay, because that's the number one objection, is I don't want to change this because Blue Cross Blue Shield has my preferred doctor in network.
Yeah. And especially in our region down here.
Yeah.
Our networks are so synonymous. And we even work with concierge facilities as well as primary care, because honestly, everybody takes money.
Yep.
I mean, a PPO contract, all that means is that we're just going to pay you money for your service. So if someone's not in a PPO contract, they still take money.
Mm-hmm.
So we're going to offer them cash,
Yep.
and it's going to be through the plan. So the doctors aren't changing, the hospitals aren't changing, but the process is. And so I think they fundamentally have to understand that in the beginning. And then the next stage is making sure that before they're going through any major whatever, whether it's an expensive prescription, whether it's a facility visit, or even just getting an MRI done,
Yep.
call the number on the card.
Sure.
Call the member advocacy, because there's somebody there that's going to sit on your side of the table, so that you have somebody helping you make decisions. And they're going to give you information to make decisions. Because today, your decisions are being made on the average by a hospital system. Because the hospital systems have purchased family practice, they've purchased specialty, they've purchased radiology, they've purchased labs, they've purchased urgent cares, they've got the outpatient facilities.
Yep.
So once you're in the system, you're in a system. And there's fine physicians. This has nothing to do with the quality of physicians. But not every system is the best at every single procedure.
Right.
And if we have the opportunity to say, hey, we got to get over here. Well, it's my arm.
I was just gonna bring it up. Hit him with your example, because I
mean,
think it's so relevant.
It is. Number one, I recommend nobody rips their arm off of their shoulder. That's something
Stuff the black diamonds.
I would advocate not to. The embarrassing thing was I was on a catwalk, but let's not go down that road. However, so I had to get the tendons reattached to my rotator cuff. Hospital was going to be about $45,000, and the surgeon that was doing it, and this was like pulling teeth, and I'm in the industry, guys. The surgeon that was going to be doing it was a fine surgeon. He did shoulders, he did, I think it was elbows was the other thing, or no, it wasn't knees, that was a different specialty. And he did, what was it, like 40 or 50 a year, which is, I guess, good.
Yeah.
And then I went to a freestanding facility with a different surgeon, and that surgeon, all he did was shoulders.
Yeah.
And he probably, multiple a day, so he's probably somewhere in the 300 or 400 a year.
Yep. Specialists.
And it was a third the cost. So I mean, so that's the concept, is that an advocate can say, hey, the person you're going to is fine.
Yep.
Keep going.
Yep.
Or the advocate could say, you know what, we got someone down the road that's got higher quality, and it's less expensive for the insurance plan, so therefore we're going to waive your out of pocket. You're not going to have to pay anything.
Right. And so I just want to reiterate that, because that's another misconception. You just presented the fact that they can still stay with their current provider.
100%.
In network, doctor referred me here, perfect. You can go down that route.
Nothing's made.
Or here's another solution that we know is going to save you money.
Yeah.
And will, and the inverse relationship between costs and care.
Right.
Yeah.
It really is. It's got to be voluntary. But it all goes back to my comment about members, is that if there's something that they're going through, or someone in their family is going through, they're at a high emotional state and they're stressed out about it.
Right.
And so if their doctor says you need surgery, go here with the surgery, they're going to say, okay.
Yes.
We're not equipped with tools to make different decisions or to get, different questions answered. And frankly, I mean, if I have a health insurance plan that my out-of-pocket is $6,000, why do I care if the surgery costs $50,000 or if it costs $30,000?
Why should you care?
Yeah, I don't. It's gonna cost me $6,000,
right.
regardless of whatever the conversation is.
Right.
So I'm just gonna go where my doctor says.
Yep.
And so that's where we came up with the 3-tier plan, so that the member now has an option. If they talk to the advocate and the advocate says, hey, go down here to the road, down the road, we're going to save that $20,000, the member benefits.
Sure.
And that's when now we waive their out of pocket. So instead of paying $6,000 out of their pocket, now they pay nothing.
So now the claims cost goes down. What's going to happen to the next year's renewal?
It's going to not be as painful, because the best way to lower what you're paying for healthcare is to pay less for healthcare.
Exactly.
I don't know a better way to say that.
I think that's the thing we need to get across the line here, is that when we educate your employees, they become better healthcare consumers,
Right.
which is going to affect that next year's renewal, right? Because now you're seeking better care, you're getting higher quality care, which means less complications, readmission rates are lower, things like that. So,
yeah. And I think the industry is starting to listen a little bit, because Aetna came out with new plans with no deductibles. It's all copay driven.
Yep.
Healthcare is coming out with their plan. Actually, United may have come out first. I think
Yep.
Aetna's coming out second.
Yep.
With 0 deductible plans. And so I applaud the industry to finally kind of hearing, us on the fringes, saying that these things, I mean, I know they hear it. I mean, everybody at these organizations are very, very smart, and they know that our average income in Arizona is $72,000, or median income $72,000, and our out-of-pocket expenses on the marketplace alone are $8,000.
Right.
Healthcare plans are at $6,000.
Yep.
That's a significant portion of someone's pre-tax income.
Sure.
Everybody knows that. We've been talking about this for years. So I'm glad that there's movement, and that's kind of a good thing too, is because if we need to stay with that, we need to stay with United Healthcare. We now have options to be less disruptive.
Right.
But in addition to that is putting tools in place and advocacy methods in place to help the members just, get redirected to the most appropriate set of care.
Right. Because if I'm not mistaken, that United Healthcare and Aetna, those plans that are rolling out for self-funded employers, the effort is still on the employee, right?
Yes.
The responsibility is still on the employee to
Yes.
use the app, and the app sounds cool, it's convenient, but it's still up to you. And how, like you just said, it's one
more
of the
reactive.
most. Yeah, it's reactive. It's one of the higher stressed times in your life. So, are you really going to be that clear-headed to make a right decision, or would it help to have a professional advocate sitting on the same side of the table as you,
Right.
to help you navigate that stress-free?
Right. Because all the carriers have care management.
Yep.
They all have outreach programs to help someone manage something.
Yep.
They have app-based tools, but when we talk about advocacy, we're talking about somebody actually picking up the phone and talking to them about that particular case that they're going through.
Right. Like, hey, I saw you.
Like before your surgery, right?
Yep.
Or before your MRI.
Yep.
That's the other thing, is that I was going to go get my MRI done. It was going to be $3,200, and I ended up paying $400 for it.
Wild.
It matters, and what you alluded to it before, it's death by 1,000 cuts, because
real money.
it's just, I'm sure at one point we're going to talk about pharmacy, and that's,
That's my favorite topic.
if you guys think what we're talking about in healthcare is disturbing, man, this is going to feel like the Mother Teresa compared to pharmacy stuff that's happening.
Legal drug dealing.
I mean, it's crazy. But on that example of death by 1,000 cuts, there's spread pricing in the pharmacy world where the PBM is buying a drug for $5 and they're selling it to the insurance company for or selling it to the insurance plan for $10. And everyone's like, it's $5.
Yep.
But what if you fill that 14,000 times in a year?
Exactly.
Because it's a statin.
Right.
That everybody's on.
Yep. Exactly.
I mean, do the math.
Yep.
So, anyway.
And so just kind of staying on the same line as, financial wellness, improving financial wellness for employees. Do you want to hit a little bit about Arcwood strategies in terms of like, okay, we're finding the lost savings within your healthcare plan.
Right.
How can we use that, how can we use those assets to then improve the financial wellness of employees,
Ideally, we're having the employer redirect some of that into the profit sharing plan.
Sure.
Because we're at we call it the savings crisis, but really it's an asset crisis because the average individual that's in their 50s has a balance that's less than $100,000. So the vast majority of our population are going to be set up to retire living on Social Security.
And they say you need, what, 2 million now?
Yeah, I mean,
Like that.
I think that's relative because it kind of includes everything.
Sure.
Somebody that makes, $500,000 a year.
Yep.
No, they're going to probably need more than that.
Sure. Yep.
Somebody that makes $50,000 a year, they're probably going to need less than that.
Got it.
So
Yep.
I mean, it's relative. But really, what we're finding out is that because folks don't have any assets to retire, they're not.
Yes. Working longer.
They work longer. So if we can create an opportunity where we can redirect some of the excess spending that's happening in the healthcare plan and redirect it into a profit sharing plan, well, a couple things are going to happen. Number one is that you're just sharing spent money with the people that are helping you make money.
Retaining talent.
Right. Right. Versus helping the stock price of the insurance companies.
Through the roof.
I mean, it's just, that's in its basic form, that's what you're doing.
Yep.
But secondarily is though, with the design of the retirement plans is you can leverage what you're contributing into the plan for the non-highly compensated, and you can benefit the highly compensated folks more.
Yep.
So you're in an environment now where you can say, well, sure, I gave everybody, 5% of their salary because we saved so much money in the healthcare plan. But now let's talk about the folks that are your top salesmen,
Right.
or your chief operations officer,
Yep.
or your CFO, whoever your key individuals are that you don't want to lose.
Yep.
Maybe we give them a 10%, or whatever the numbers. I mean, it's all mathematically actuarial. But the point is that you're using money that you already spent. You're redirecting it to the employees that are helping you make profits inside your organization.
Right.
And then you can leverage that to help benefit the higher compensated individuals that are inside your organization. Because you want to keep them, you don't want to have them get headhunted away.
Right.
Because it's terrible to lose an employee because they think they're going to make a couple more bucks an hour.
Right.
You want to,
Or because the benefit package just appears to be better. Right. Yep.
That's true. So that's part of the strategy. It increases the financial well-being, and it's sorry for you folks that work at the carriers. We're talking about taking the money away from you guys. And putting it over to the employees.
Yeah. But that's what we're here for, right?
That's why.
Helping employees.
Yes.
Like I think of my own mom, and I've shared this story with you, Pete, but works at a nonprofit in Connecticut, makes about $45,000 a year. Her out-of-pocket maximum is $7,000.
Yep.
And her monthly premium is $688.
Yeah.
That breast cancer survivor has to repeatedly go back for labs and exams and things like that. And it's like we say, it's just not sustainable.
Not for her.
For
She doesn't have the
individuals
cash
like
flow
that.
to do it.
Exactly.
Yeah, not at all. And she's the majority of the population.
Right. Let's say the people that are not paying their medical bills are actually the people that have insurance. So that's always an interesting fact.
Yeah, if anybody knows anybody at a hospital, call up the receivers. How much money do you guys have in collections right now?
Yeah. So you want to hit on that a little bit because it's a unique thing that we can do for employers is kind of that direct contract with hospital systems. You want to hit on the Kentucky Bluegrass Project a little bit?
I can't take credit for it,
Yeah.
but I know the folks that are doing it. But it was a fascinating study where it was a 240 life company that working with an advisor like us, because we're part of a national practice organization, so, and this is how I learned about it, because I chit-chat with these guys on a regular basis. But they went to the hospital system. It's a smaller town. And they're like, my employees are coming here anyway. Can you give me a 20% discount off of what the insurance company is paying you? And the there's a lot of conversations. I'm paraphrasing this. It gets up to the CFO level, and he says no. I don't. How can we take a 20% hit off what you carry? It just not makes sense
on paper, right?
The person that we were working with inside, the person that they were working with inside the hospital system was in the finance department, and she was doing collections. And what she had realized is that if they accelerated their collections or their receivables, then their margins actually go up. So remember I talked about we have 3 different levels in our plan designs. Plan level 1 is take the direction of the advocate. You go to these certain facilities, and hospitals do us. Every hospital in the nation does this already. If you come here, you pay nothing. If you go across the street, you got your deductibles and co-insurance and everything else. I mean, I like to plagiarize stuff. I'm a smart dude, but I don't have to come up. Why would we reinvent the wheel if you don't have to? So the plan designs are basically saying is that employees are going to be coming to this hospital system. They're not going to pay anything. So the hospital is going to get 100% of that number.
20% less, but 100%.
Yeah, but 100% of it within a week. And because they didn't have to go to collections for trying to collect the money from the employees, because in the prior scenario where they had the 30% increase in fees, they weren't collecting that because they still had to chase the $7,000 from the employee, or they still have the collections for pennies on the dollar. So the person in finance showed that to the CFO, and she said, technically, if we do she didn't like. I think the first question was a 30% discount, and that she didn't like that. But I think they got down to somewhere in the neighborhood of about a 22% discount, and actually increased the hospital's margin.
There you go.
Because they removed collections.
And then weren't they like, bring us more? How do we do this?
How do we add more employers into this? Absolutely.
It's funny how people are resistant to change, and then they realize how good it is.
Well, and that's it. And that's why we like to create the relationships over a period of time where we can, my largest carrier here is probably Blue Cross Blue Shield. I mean, I have friends that work there. We maintain those plans, and so it's not like we're trying to just shake up the jar and dump everything out. But we want to create a relationship. We want to educate, and then when the employers are ready to make these changes and these decisions, then we're there to help them do it.
Exactly. Perfect.